You might want to mute. You might want to mute unless you're speaking, and we'll try to get everybody involved. Good morning, everyone. I'm Dr. William Thornberry. This is Physician Technical Advisory Committee. This is May 20, 2022. We're meeting under the auspices of Title 19. I'd like to call the meeting to order. Let the record show that we do have a quorum, which would include Dr. Neal, Dr. Tran. Dr. McIntyre is here somewhere, I believe. Is that right, Amber?
Yes, he is on. He doesn't have his video on, but he is here.
Okay, and then I'm here, but that's still going to give us a quorum. Our first order of business is to approve our previous minutes. It probably was included in the packet. May I have a motion, please?
So moved, Dr. Neal.
A second. Is that okay with you, Dr. Tran?
I can second it, yes.
Very good. In favor? Any opposed? None opposed, without objection. We have a pretty dense agenda today, so I want to thank ahead of time our team, including Amber, especially Cody, who's on honeymoon, for putting this together for us. And I want to thank the people, our partners with the MCO working partners we have in DMS for making time to look through this. Our first order is a piece of old business. Item one was an update we requested from DMS on the complexity E&M service. I think that involves 907 KAR 310. Amber, can you catch us up here on this?
Sure. This has been kind of an ongoing issue for a while, has been discussed quite a bit over the last probably year and a half. This was a recommendation that the PTAC made to change this regulation to get rid of the limitation on complex E&M visits. And that PTAC made the recommendation to the MAC, which the MAC accepted. And I believe at the last meeting, it was brought up, or the January PTAC meeting, that DMS had suggested that this regulation was opened and being looked at. So for any potential changes on that issue, particularly Section 11. So I'm just wanting to get an update and see if there's any additional news on that front today.
Well, I would pitch that over to our DMS partners if they have anything for us, if there's someone that'd like to speak on their behalf today.
This is Lee, guys. I'm just kind of waiting to see if anybody else wanted to speak first. But, it's still in the still in line. It is still on the table. We believe that it will happen. We cannot tell you when it will happen. Is that a fair statement, Jonathan?
That's correct. We do intend to make these changes. That there is a draft that's circulating, but that there's there are some there's another issue with that specific reg, so that is why it has not yet been filed. But we hope to have it filed in the coming months.
Well, thank you, Jonathan. It's good to see you.
Good to see you.
Dr. Tran, Dr. McIntyre, Dr. Neal, do you have any thoughts on this that you'd like to bring in?
Yeah, Dr. Thornberry, this is Twin Tran, and for my educational purposes, certainly we are all very concerned about ensuring that, sorry about that. We're very concerned that we must ensure that Medicaid is solvent and that we don't have obvious abuses of this complex code. But from our standpoint as a clinician, there are many times where our patients do meet this complex code and we would simply like to use it. So I guess what I'm trying to ask is, can you, from your perspective and from DMS, give us some explanation as to why there was a limitation to begin with, just so that we can better understand your perspective?
The limitation, it's my understanding that the limitation was put in place some time ago to help contain cost. That's I imagine a reflection of someone else's abusing the 99214s, and it's just 14, or is it 15? Anyway, I'm sorry, the E&M evaluation codes, the more complex codes. I would imagine it was in response to an abuse some time ago. Those limitations have been in the regulations since I've been with Medicaid 10 years ago. So they were made over 10 years ago. And we've done some evaluation on it now. We've taken comments from you all. We have taken comments from our own medical director, and we do have a clear intention to not correct it, but to remove the limitation. So we're working on it.
Thank you. Dr. Neal, you really are emeritus
Does that
chair
help?
and historian.
Yeah,
Well-
does that help, Dr. Train?
Yes, that was my my thought process as well. And if I may just insert one comment, and that is, again, as a provider, I rarely have any intent on misusing. And so I guess my recommendation is for future references, perhaps something that we can consider as a group is that if we do encounter such things, maybe we should target the offenders and not necessarily have a regulation across the board that limits. I'm not articulating it well, but I think you all get my point.
Thank you, Dr. Tran. Dr. Neal?
Yes, with all due respect, Lee, this was not really about abuse. It was about limiting cost from the very beginning. And I think you're really aware of that. The problem where abuse came was that they were changing the codes. If we did it 99214, it was either not paid or paid as a 213, which left us actually abusing by submitting a 213 when it was really a 214. And of course, study after study now shows that probably 40%, maybe 50% of the 99 codes are probably 214s now anyway. And of course, the EMR and all that has brought that out. So we're just way behind the curve in getting rid of this, Lee, and we've just got to have that. I mean, that's a small thing really, but it's got to happen really soon.
Thank you, Dr. Neal. Dr. McIntyre, do you have any thoughts, sir?
I would just concur with Dr. Neal and Dr. Tuyen with the remarks they made. It occurs to me that fixing this could be kind of a budget busting event for Medicaid, and obviously they need the funding from the legislature to be able to do this if it is a budget busting event.
Thank you, Dr. McIntyre. I would certainly not put any of our MCO colleagues on the spot unless they really wanted to chime in on this. From my seat, the way I would look at the world, I would say this is just good generalship. You know, the MCO partners would do what they would want to do. They're there to have profit so they can propagate their mission in the Commonwealth, and I don't disparage that. I do think, however, from the physician side, in fairness, we're asked to comply with correct coding. I think it's been iterated that, I can tell you about my clinic, which is chronic disease. I mean, well, I'm sure we have a few level 3s that come through. It's just not, I mean, when somebody comes in and these people, I have people that are not coming to the doctor now because they simply have to pay other people to bring them, and the cost is so high, they're not coming, which is another issue we're going to get to in telemedicine. But what happens is it's like when they go to Walmart, they have $10 and they're trying to get as much as they can. And for most of us in the real world, they come in for their diabetes, hypertension, dyslipidemia, but they're trying to get other things. My shoulder hurts today. Can I have a shot in it? Can I do this? And I think, when you're compassionate, you want to try to provide as much care as you can. The other side of that is you look at the end of the day and you're like, well, what happened? I couldn't get as many cases in and I can't run my practice. And so what we want to try to provide is a Pareto optimum, I think, where everybody can win here, but we want to be honorable with the MCO and the Commonwealth and try to help us understand the burden of chronic disease care here, what that's going to cost us. And we don't want to really disparage the workforce, because the morale of the workforce, and with inflation at 8+%, I think, we can't raise our rates, and that's becoming a more stressor. I don't think we need to beat this. I would just say, I would thank our MCO partners for helping us try to look at it from our point of view. And I would thank DMS for working on this. And Jonathan, I understand completely where you guys are at on it. But we just wanted an update today. Is there anybody else that would like to add something to this comment? Or if not, we'll just move on, but I'm happy to open the floor to anyone.
This is Dr. Terrio. I just wanted to say that thank the TAC for bringing this to our attention, because we did not realize, or at least I did not realize, that we had a limitation on those codes. And so we are trying to be responsive and to, address the issue. And I know it seems like it's taking a while, but it will be done. And just thank you for working with us.
Well, Dr. Terry, I can't see you, but I'm not a pro at this, so you'll have to excuse me, but it's always nice to have you here, one of my mentors. And again, I would close by thanking our MCO partners. And I guess the quid pro quo is what we would ask you to do is this. We have Starfield's medical home model. Dr. Starfield's model has never been disproven. And I think if you invest in your primary care workforce, that it will pay dividends for you in a number of ways. And I think that will be profitable for you in the long run. And so I would ask that you have a little faith in this one on your primary care team. I know this affects other people, and particularly Dr. Tran spoken on behalf of specialty groups, but I think it will be better for us in the long run. If there's nothing else there, I'd like to go ahead and move us into our new business, please. Our first item here is an update from DMS on efforts related to implementing value-based payments tied to our quality measures. That is the physician impact. Amber, you want to bring us up to speed, please?
Sure. I think there have been some ongoing conversations here at the PTAC and within the MAC on DMS looking at value-based payments that are tied to quality measures. So just again, interested to hear any updates on efforts around this and, the impact that would be on physicians. Just an update on if there's any more discussions ongoing about, like I said, value-based payments for quality measures.
Dr. Neal, I'm going to lean on you on this one. You really have our significant expertise here. Would you feel comfortable kind of leading us off, sir?
Sure, be glad to. Well, this is kind of deja vu to us. We had something called KENPAC years ago. Kentucky led the nation in doing value-based payments to primary care, and it was based on what we called HEDIS measures at that point, which were certain measures that if you met those, then you got so much of a per member per month added to the payment. And that's basically what kept primary doctors' doors open in Kentucky for a number of years. And even when the HMOs came online, a few of those have continued those to some of the groups in Kentucky. But wrestling with value-based payments is just, there's article after article being written, and that's really very difficult, because to me, that brings physicians into more of a risk into payments. And the MCO's risk is built into their structure, their pay structure, and all of that, or reimbursement structure. And for that to be built into a medical practice these days is just really difficult. So I think this is going to be a long discussion. I would love to hear what Lee and the others from DMS have to say on it.
Well, I guess on that note, Lee, do you want to step up to the plate here?
I can step up, but there'll be nothing but strikes from me on this one, because I apologize. I'm not.
That's great.
I am not. I could talk about softball and baseball, with you all for a while, but as far as value-based payments, that's just outside of my expertise. And I apologize for that. I do think that it's a conversation that's been taking place. I could ask a quick question of Dr. Neal, if that would be okay. Dr. Neal, were you
Sure.
were you indicating that it wouldn't be your recommendation to go toward value-based payments, or are you just were you indicating that you thought it would just take a long, long time?
I think it will take a very long time to figure out how to do that, because if you look at, does value-based mean that it's based upon the results of our treatment of patients? In other words, would the values be placed upon whether diabetics are properly cared for, et cetera, out into any disease process you want to talk about? Or does it mean that pediatricians, for example, are giving 90 some odd % of the immunizations that are required of children? Those were kinds of things that we had when we had KINPAC and we had the HEDIS measures. And I'm not totally against it. I think just trying to figure out how to do it is going to take a generation. Go ahead.
Hi, this is Angie Parker. I'm with Medicaid. I have been getting some information regarding with the MCOs on the value-based contracts that they have already established. And yes, we are looking at value-based contracting or value-based programs associated with whether it's HEDIS or quality measures, with CMS type measures or the HEDIS, which are usually pretty comparable. They're, all MCOs, with the exception of one, have some sort of value-based contract with certain providers. So that is happening. And it is, whether or not you've been contacted by an MCO to do a value-based contract or not, they are willing and able to do that. I guess to Lee's question as well, it sounds like you have a concern about value-based contracts.
I do. Bill, if I could add one more thing. Let's
Yes, sir.
use Medicare instead of Medicaid as an example. They formed the ACOs, the Accountable Care Organization, several years ago. And the idea there, of course, was to have value-based care, and the savings to Medicare would be returned partially to Medicare and partially to the providers. And that certainly is value-based. Unfortunately, what Medicare has found in the last year or two on evaluating that is that they were not saving money. And so Medicare now has, and somebody correct me if I'm wrong, but the last thing I read was they had chosen 8 states, one of which is not Kentucky, to do what basically was our KINPAC system, was a monthly additional payment, which we did with KINPAC, to providers as a value-based payment. And it's interesting that Kentucky was not chosen, and maybe somebody could speak to that, because we were one of the leaders in that particular kind of payment several years ago. North Carolina, who basically took our KINPAC system and ran with it and was very successful for a number of years, is one of those states, I understand. So I'd love to hear some more discussion on that. Maybe somebody from DMS would know why we were or were not included in that pilot program that Medicare is going to do.
Thank you, Dr. Neal. I'll certainly open it up to DMS. I have some thoughts on that. My first thought is generally, politics is power, and, Kentucky, is not in a position to be commonly thought of if you're going to be a pilot program. I understand that. Dr. Terrio, I don't want to step on your feet here. Is this something you feel comfortable with before I kind of get into things?
Well, I just want to, what Angie said, the MCOs are open. They have some programs ongoing, and they're open to new programs. And And it could be something as simple as Dr. Thornberry, you were saying, you have chronic, a lot of chronic patients. So if you say, I can take care of my diabetic patients better if I had a diabetic educator on board, if I had, a patient navigator on board, I don't know, I'm making this up, and then approach the MCO saying, hey, I can do this, give me some more money and I'll make the metrics for you. It's something as simple as that, or you can make it as complex as you want it to be, with an across the board thing for vaccinations. And so I think everything, because it's so new and because it's, it's not new, but we don't have that many right now. And it's because people don't know what to do with it. And so I think it's going to really take, people on both sides, the MCO side and the provider side, to come up with ideas and to basically test them to see if they work and increase the value for the patients.
Thank you, Dr. Theriault. The way I kind of look at it is something like this, and it may be a little simplistic. When the AMA developed the CPT coding, of course, it was developed for medical specialties, and the way that the medical specialties work in our health system is considerably different than what the health system is asking primary care to do. And that's the genesis of people and organizations that have, over the last maybe 2-3 decades, have talked about value-based systems. The reason is your primary care workforce they do encounters like you come in, you have a problem here, and we fix the problem, you go out. It is based to some extent that way, but primary care also has a lot of other things that they're responsible for. And the way the CPT coding was developed, it really doesn't take into account what you're asking your primary care workforce to do. And so a lot of the wisdom coming out from some people like the Patient Primary Care Collaborative, that was Dr. Grundy and that group. But those people said, we need to have a way to try to compensate these people for what they're doing so that they're sustainable. And that yet comes back again to Dr. Starfield's work, which is if we can have a sustainable primary care system, those systems, again, have been proven to lower cost and get better outcomes every single time. So I think the value-based systems were based on that. Now, I would see that maybe as the apple, and Medicare is more like the pear. They're fruits, but they're different fruits. With Medicare, I see that more of that was kind of a sly bureaucratic initiative, where there's a certain pot of money and every year everybody's trying to get better, but the pot of money doesn't go anywhere. And so what happens is, I think at first you have winners and losers, but very quickly everybody regresses to the mean. The problem is you put more and more resources in, but you don't get more outcome, and it may drive the quality up. But the greater point is those practices can't sustain it. Nobody can really sustain that type of system. And I think somebody kind of knew that when they set it up, as far as I'm concerned. That's why I think eventually I think a lot of us predicted it wasn't going to be able to work. I think what we're asking here is, but let me put it this way. I think we're applauding the effort toward DMS and people that have that mature mindset to say, maybe Kentucky, something came out this week that says we were maybe 10th or 11th in the country in our primary care workforce. We have about 125 per 100,000. And in Kentucky, where we have a very rural area, this is even worse because it's compounded by the fact that most of those are in the cities, as we all know, and we're not immune to that. But we have a real challenge. And I think the wager that the MCOs have to decide is, are they going to bank on a system where you have physician assistants and nurse practitioners providing that care, or they're going to be physician-based systems where the physicians are going to stay engaged? Well, I think Hattiesburg is just another, that was out, a month ago, where the Hattiesburg project said they had a complete system just like that, and it didn't work well at all. Kaiser looked at this a decade and a half ago and had trouble. But, I'm not here to tell them how to run their business, but I would say, I think wisdom here from DMS would say, if you can keep a physician-led workforce there, they're going to build teams, and those teams are going to be responsible. And then most of us don't look at this as economically, as there's a lot of budget constraints, I believe, on both our MCO partners and DMS. We look at this more altruistically, like we're in this profession to serve. We're trying to serve this population, and we're trying to do it in the most efficient way possible. I think that it's money that on the near term for the long term. I think if you can use these value-based systems to keep your reimbursements to your primary care where you can keep them engaged, you're going to save money in the long run. And if you don't, I think it's going to be I think it could be, we've talked about this before, and I don't want to be hyperbolic, but I think it could be catastrophic. If enough people begin to drop out and say, this just won't work for me, then that's going to really be a serious problem, because we just have too many people in Kentucky that have serious chronic diseases. Those are kind of my extended thoughts. I didn't mean to be so long-winded, but I think that's the genesis and where we're going with this. And I would say, again, from our point of view, we applaud the effort to look into these systems in a mature way. I think Dr. Neal said it best. We were doing something like this. It was really successful. And then for reasons that are not really clear to me, we moved away from it. It could have just been the way the wind blew. I would open the floor to our MCO partners or to anyone else that would like to comment or have some insight into this more than we do.
Hey, this is Tim Houchin.
Yeah, Tim, please.
So I don't know. I guess I would preface this by saying I'm really just speaking as a doctor, not really as a representative necessarily of an MCO, although I know I can't completely sandbox those things.
Well, we wouldn't hold you to that. Thank you for your
But
thoughts.
when there are regs and sometimes laws that really enhance reimbursement for mid-levels, it makes it hard, I think, for physicians to advocate for their particular value, especially when it comes to being captain of the ship, let's say, of a practice that might have 5 mid-levels, and if the reimbursement is stipulated that a CRNA, for example, must get 100% or even 75% of the reimbursement that a full-blown anesthesiologist would get. And that's just one example of a recent reg that I don't fully understand. It makes it hard to see the quote value in those physicians. And I know as a physician, we bring tremendous value. But anyway, there just seems to be a lot going on in terms of forcing, equitable reimbursement for mid-levels. Does that make sense?
Well, I would say, for what I've seen in our Commonwealth the last 20, 25 years that I've been working in here, and I'm going to speak very candidly here, I see what I would call education by legislation. I see interested groups come in and they use their expertise and their resources to do what they're going to do in a capitalistic society. They're going to try to advocate for themselves. I think the difficulty with that sometimes is there's a lack of maturity and understanding the long-term consequences. I've never met anybody that felt like they were paid for what they did. But that being said, I'll just take a picture, just a very slick slice out of a future that I see. Suppose that we have legislation here that makes all mid-levels equal to, say, physicians, and their reimbursement, they can write and control substances. There's no difference. You can hang up your own shingle, you can do that. Well, Professor Friedman would say, in a fair free market capitalist society, we should consider doing that. The problem with that is, think about one of the missions of the Commonwealth. The Commonwealth basically invests in these medical schools, and we have 3 to train physicians, and we're supporting that. And so we do that, and then we train them with residency spots because it's cheap labor. But the people don't stay. You see, we train them for other states. We're investing the people's money, and then they leave because there'd be no reason for them to stay. Why would you ever stay here? I mean, a few people might because their mom and dad are here, but the great majority of people are going to leave. And then you have to explain to the taxpayer why that is exactly. And then once that begins to happen, then all of a sudden you're in a terrible, terrible death spiral, because then no matter what you do, why, you may never get those people back. You just may become a desert of healthcare. And if all the care were equal, again, if my physician, I'm married to a nurse practitioner, I work with 2 physician assistants, and there's a wonderful spot on our team for them. And they do wonderful care, but when you use them adequately and appropriately in these teams, we get excellent outcomes. I mean, there's just no debate about that. When they begin to work independently, again, I'll just talk about the most recent piece from Hattiesburg. Hattiesburg data in Mississippi had the largest health system down there. They had a mature health system. It was well managed, and they said, over here, we're going to manage physicians. And in the same clinic, we're just going to manage the nurse practitioners and physician assistants by themselves. We're not going to give them any physician oversight. Their outcomes were not good. And they published that. They came out and said it wasn't good. And so I don't know if there's a lesson there for the MCO partners, because I mean, they're going to try to get the most, like every capitalistic system, we're trying to get the most out of and pay the least they can for it. That's the way our system works. And there's reasons that it works well that way. But at some point, the referee has to stand up, and there has to be an adult in the room. And that's what we would hope our DMS partners can do, is to say, you know, we have to officiate this. And for the long-term good of the Commonwealth, these are probably going to be the things that are going to be most successful. Barbara Starfield's work, again, over 3 decades, was based on physician-led systems. When you begin to extrapolate from that, say, well, maybe nurse practitioners can do this. I mean, they're always going to say they can. I get that, but the data doesn't prove that out. And so when we work at value-based systems, we have to have the Commonwealth decide how the system is going to work for them, so that in the long, no matter who the administration's working in power, no matter who is in the legislation, that we can take care of the people in the Commonwealth. Because with 4.6 million people, you know, I got one guy working for every one person on Medicaid. And that is a system that is almost destined to fail. That's why we moved. I specifically moved us toward telemedicine, because I thought it was an opportunity for us to save money. I hope we're saving money, because I just don't see any other way that we can work our system. We have to be more efficient about the way we deliver it. So I didn't mean to get into an epistle here, but I think that's the belief here, in trying to speak to my Medicaid partners, our DMS partners. That's what we're thinking. We're thinking that at some point you may have to help us with these type of systems to sustain your primary care workforce, so that we can do the role that you want us to do, and do it in a way that makes sense. And that's what we need your experience for. Are there any final thoughts on this from any of our partners at all?
I think you hit the nail on the head that the system has to change. And I think because it's not working, at least not working for primary care, what people want primary care to do within this system that we have right now. And part of the tools we have to make it change are the value-based contracting. You know, and so we have to really start to create, you know, a system that we want, and then use our MCO partners to see if that's going to work.
Thank you, Dr. Theriault. And I would close this topic by saying we appreciate the effort and the initiation from DMS to look at this. And again, I do think that it's wonderful to have our MCO partners to try to help us, because I'm sure that throughout the country that they have a lot more experience than we do. But hopefully we can find a system that will help everybody accomplish what they want to accomplish. And I would say, again, thank you for taking this matter up. We'll keep this open to kind of follow up on. If I could move us along to our next item, I believe we're on item 3 here. Update from DMS on the average annual number of incomplete payments to physicians in the Medicaid program. Amber, you want to kind of catch us up here?
Sure. As part of the agenda, it was included an article published by the Mayo Clinic on the healthcare expenditures that were attributable to primary care physician overall and burnout related turnover. In the article, it states that the turnover of primary care physician results in about $979 million in excess care expenditures for public and private payers. And about $260 million of that is attributable to primary care burnout related turnover. You know, there was another article, I think, I'm not sure if this one was linked, but it was published by the National Bureau of Economic Research that estimated that physicians lose 17% of Medicaid revenue to billing related problems. And that's compared to about 5% for Medicare and about 3% for commercial payers. So with these kind of data points in mind and the interconnectedness between some of the administrative burden and billing problems with physician turnover and burnout, The PTAC would just like to get a little bit better understanding of how that is in Kentucky, the number of incomplete Medicaid payments to physicians, as well as physician turnover rate in the Medicaid system.
Thank you, Amber. Does anyone from DMS want to chime in about this? I would open up to you guys firstly.
In order to give you all any data on this, of course, it will take some time to collect it. How would you, we would need a written request from you. We need for you to include a time frame. And then likely have to have another conversation about what the data points are and how to collect them. But we can certainly provide that data to you. If you had all that's needed is something in writing asking for it.
Yes, ma'am. Well, maybe we can come back to that. Dr. Neal, Dr. McIntyre, Dr. Tran, Dr. Gupta, do you have any thoughts on this?
Dr. Neal, I would make, in my 40 some odd years of working with DMS, I have to say that I can defend them strongly from the standpoint of payments to the PCPs. They kept our doors open through times when there were shortages. They made estimated payments. They did everything they could possibly do. And I know Lee goes back to some of those times. And so I don't know exactly what they mean about incomplete payments, but I can defend them strongly on what they've tried to do to keep the PCP force there to take care of Medicaid recipients. Now, I know there's incomplete payments that has been a problem for the federally qualified health clinics who are paid on a cost plus basis, and somebody can correct me there. I'm not sure if those are now up to date, but those are payments not necessarily to physicians, but to those groups. So I just want to make that comment because we can defend them mightily for trying to get physicians paid.
Thank you, Don. I would echo that too. Yeah, I'm not sure how we got this on the agenda out of it. It doesn't really matter. I do think this is worthy of chatting about. My thought on this would be, when I look at it, I would say, well, a recent article came out. I don't know what the survey was, a very large survey of medical physicians. And it's something, if I understood the article correctly, you all can correct me if I'm wrong, but I think it was something to the effect about in the next 3 years, 40% of these physicians are going to be 65 or older, and they're going to either stop completely or cut back very substantially. And that's and of course, I think, again, in our position in Kentucky, I think we're going to take a substantial hit there, maybe more than the average. I think we're going to be above the average on loss. And so those things that, like, if we had things like incomplete payments, things that might disparage the medical workforce or affect morale, that's something that I guess we would just call attention to DMS. I don't know that, I don't know if there's a problem here. I know that, like, for example, with MCOs, they have things like ghost physicians that are on their rolls but see little or no patients. And it's those types of things like this, where, if they're not being fully reimbursed, and, the reimbursement is generally pretty meager, it could be an issue. Gosh, Dr. Terrio, do you have any thoughts on this? I don't, this is not my expertise. I just don't, I don't do the billing in my office. It's done out of state. I just go to work, I use on my schedule.
I'm not sure actually what this is referring to about incomplete payments, but as far as the workforce, I am worried about the primary care workforce retiring, and people, the young physicians aren't going into primary care for various reasons. Student loans is one. They can't pay off their student loans because they have, $200,000 and $300,000 in loans. Can't do that on a primary care salary. But and then the training is, in my opinion, mostly hospital based, and that's where the graduates are most comfortable, and they're not comfortable in an office setting. And so when they're finishing their training, they're going into obviously what is most comfortable for them, which is hospital-based. So I do think we have a big problem with medical education right now that also needs overhaul. But sorry, that's my 2 cents.
Stephanie, does GMLS have any thoughts on this, or do you feel comfortable in chiming in here? I'd like to get you involved. You're not getting any complaints here?
Well, we get a lot of complaints and we try to track them. So like the plan is to try to track them and put them in buckets. So to see if we have trends of the complaint or, so a lot of it is education back on the practice. I don't have anything right now that stands out to me as a trend.
Well, does anybody else have any thoughts on this at all?
I
This
want
is
to say
Dr.
very quickly,
Yes.
Bill, if you don't mind, we're going to have some serious discussions about the future of primary care, because we're not even filling the residency programs. There used to be match day and it was an exciting day. Now there are matches that go not filled at this point. And there's a tsunami of changes being pushed by the mid-levels for equal payment, for equal treatment, if you would, from the mid-levels. And so I think we're going to have to start. This is supposed to be about Medicaid. That's what we're all about, basically. But we're going to have a discussion from Secretary Friedlander, Commissioner Lee. We're going to have to get involved in all this pretty soon, or we're just going to face this tsunami of a disappearance of the primary care. And if we're going to shift over from the treatment of sickness to the maintenance of health, which is what value-based is all about, we're going to have to be futurists in our thinking. And we're really behind the curve. So I could talk about this for hours, but I would suggest that as an end point, we've got to have some serious meetings face-to-face with discussions of this very soon.
Well, what I would say before we get to Dr. McIntyre, to answer your point, I'll speak kind of on behalf of what I would say the physician point of view here is we would say, one, we appreciate what DMS is doing on our behalf. Two, I don't think it escapes us that the leadership in both the cabinet and DMS understand these issues. But in fairness, I would say that we would kind of gently whisper in your ear that it might be about time to consider on a strategic level if it's time to have some type of a summit or some type of very serious consideration about the future of healthcare in Kentucky. But those are things that have to come politically. Those are political solutions, and that's not our role here. I would say that I would trust the DMS leadership to work in the way that they work with their colleagues in the executive branch to try to decide what's best for the Commonwealth. We have to rely upon our partners to do that. And I do trust them to help us with that. So I think, Dr. McIntyre, I know you wanted to say something, sir.
Yeah, I'm on this idea of people leaving the workforce because of age. I'm retiring this month from emergency medicine because I've aged out at age 73. Hopefully I'll find something else I can do in medicine in the Commonwealth. I've never had to deal in emergency medicine at all with value-based care. I'm wondering how much of an administrative burden it is for physicians like you, Dr. Thornberry. And I'm also wondering along the same line, how much that administrative burden, if there is one, affects morale of the primary care workforce and also affects people not wanting to match for those residencies in primary care.
Well, it's a pretty big can of worms that we're talking about here, and I'll try, since we don't have a week to talk about it, I would comment that what Dr. Terrio had suggested, that inside of medicine itself, for reasons that are not clear at all to me, primary care work has not been highly regarded. And that's the reason that I went into primary care. I was at the top of my class and I thought it was the hardest job. And I said, I want to devote my life, my career to the hardest intellectual job that I could. And that's why I chose to do it. I understood it didn't pay well, but I don't get to decide that. I have to decide what, God put me on the earth to do. And that's what I'm supposed to do. But that being said, I think the specialty is coming to crisis. I think that our country's coming to crisis on this because it's a system. It was set up for 40 years to say, well, when we vote on things, there's 37 votes one way, there's 3 votes another way. And after a while, you can just see there's a big delta that begins to develop and it's a problem. That being said, you know what? I can't solve that problem here today. What I can do is I could just say that we could gently tell our MCO partners and our DMS partners that we have for several years been ringing the alarm bells about the crisis we're coming into. It is true that we're not getting people coming into this specialty. They're not staying in the specialty. And if you don't have a lot of prestige within the medical community for whatever reason, it doesn't matter why, the only other the carrot that I think you can offer them is some type of economic carrot. And to answer your question, lastly, to try to give you some insight, I'm not an expert at this, but I would tell you every day is very challenging in a primary care office. It's people, for example, just by example, I don't know, say I'm in urology. Well, people come in, they have about 5 major diagnoses, and there might be about another 10 or 15 smaller diagnoses, but it's, listen, I've done that work. I did some general surgery residency, and that's another hard job. But you know what, when you only have 5 or 6 or 7 things, it's easy to get, 50, 60, 70 patients through a day. You just can't if you want to do that. In primary care, these people don't come in with labels. They come in like, I'm not feeling well. And, and you can choose to ignore it, but you do it at your own cost because a lot of these people are 60-year-old diabetic ladies. And that's what they come in when they're talking about MI. We have the burden of prior authorizations that have come that nobody pays for. And it's not like just a medicine or two. It's like, it's every patient now. I mean, it's a 30-minute wait on every patient. And again, I would say congratulations on the generalship for that, because eventually you just wear the primary care workforce out. There's only so many people that you can afford to pay. There's only so many phone calls you can make when you're talking about imaging or this or that or the other thing. And it does what it's supposed to do. I bet it does cut the cost down, but it's penny wise and pound foolish. I mean, we talked about this before. If I want to get the CT and the CT has to be done, well, you may not pay me. And on paper, it looks like you fooled one on old Dr. Thornberry. But then they got to go over to the ER. I mean, I got to send them across the street, and then it's going to cost more. And then those guys are not going to know what to do with it. They're going to come back. Now we're paying twice. You paid them twice to see me, and I'm the guy that has to do something about it. It's just the whole system, the whole cabal is messed up. And again, I can't solve those problems, but we can call the attention to our DMS partners to say there is a genuine crisis here, and we hope that they will use this opportunity to lead our Commonwealth. And I, in my position here on behalf of the physicians in the Commonwealth, I can only call your attention to it. And I have to rely upon you as our willing partner to help us to provide leadership here. We can't provide this kind of leadership. Does somebody else want to, before we kind of close this thing out, does somebody else, an MCO partner, want to speak, or Dr. Terrio or somebody from DMS? Well, I don't blame you. It's a lot. And again, it seems like everything we talk about kind of ends up back here, and, and maybe that does for a reason. Maybe this is the least common denominator. If it's okay, I'd like to just move this along because we could talk about this for a week. And I trust DMS to do what their leadership feels is appropriate here. Is that okay with everybody if we move on?
Yes.
Okay. I'd like to take us to item 4, which is equity and telehealth. Amber?
Sure. Also included, a link in the agenda was an AMA, American Medical Association brief on telehealth equity, along with some key steps that they recommend for ensuring an equitable telehealth landscape. I won't go through and read every one of them. I'll just point out a couple of them. One of them was to include, fund, and implement programs to provide internet-connected devices and broadband access. It says in 2021, 20% of adults in the United States did not have a home broadband subscription, and 15% did not own a smartphone. Another one was programs to help measure and strengthen digital literacy, with an emphasis on creating programs for the patients. Internet access and device ownership only benefits the patients if they know how to use them. And expand physician practice eligibility for programs that might help them buy and service the equipment for telehealth, and really increase device use among patients, and increase telehealth inequity. And then also requiring health plans to cover telemedicine provided service on the same basis. We do have some statutes in Kentucky about that. But the second part of that was payers not limiting services provided by kind of the corporate telemedicine providers. Continuity of care is kind of undermined if patients are directed to kind of a separate contracted entity instead of their regular physician to provide telehealth services. So those were just a few thoughts on promoting telehealth equity. And I guess, Dr. Thornberry, you just want to see if DMS is doing any work in that space?
Yeah, well, thank you, Amber. I'd like to open it up. Would someone like to kind of carry the ball here for a minute on this one? I could talk about this all day. This is my wheelhouse, but I'd like to see what other people have to say about this. Well, hearing none that want to kind of dally into the water, my initial thoughts on this go something like this. I think it's when you look at something, it's a matter of what your perspective is, what the relative perspective. If I'm the MCO, I'm like, wait a second here, we have in-house people, we think we can provide it better. Of course, when you make that kind of statement, you're thinking, well, you're talking about acute care, like what I would call minor acute care, minimal cough and cold, poison ivy, that kind of stuff. And that can be provided. I think that you can make a very good rational argument that you could try to say, well, we're going to try to provide the best care we can for the least amount of money, and that would make perfect sense. The problem is that's not where the money's being invested, and that was never the intention of Senate 112. In 2018, 112 was designed to basically get people into the game, and we use that, I don't know, 20%, maybe 15% of the health dollar, where they're getting some pretty simple cases to get them into the game. But in Kentucky, again, I think 85% of the healthcare dollar that we have, as I understand it, is chronic disease care. And that really can't be conducted by, the internet provider from Wyoming. That's something that has to be done, because sooner or later, you're going to end up in that primary care clinic. And when you say change their hypertensive medicine, their diabetic medicine, or their thyroid or their lipid medicine, at some point, you're going to have to order a test or something's going to go wrong. And that's the point that we want to try to, I think, accomplish, was to get chronic disease care online. If we could do it efficiently, then the only way we could see to do that was to pay them what it would cost to come in, just pay them that reimbursement, so that we can get those people out of the clinic that don't need to be there. So when people want to come in the clinic, that there's room for them and you're motivated to get them in the clinic. I guess the point of what I would see is with the term equity in telehealth would be, we have at-risk populations. Some of those are, intercity populations that don't have access. We have people in very rural areas that don't have access. We have communities of color that don't have access. And telemedicine was used as a means to try to make that delivery model more equitable so that they do have access. The fact that, again, that we were talking earlier about, we have 40% of our population in physicians that may be trying to leave. Well, in order to keep that access available, this makes that transaction, that delivery model, appropriate. When I think about it in chronic disease care, again, I would say, well, if I'm the MCOs, or maybe someone that would take an economic view, say, well, I don't want to pay for phone calls because you can't do the same thing. And I would say, wait a second. I work with ICU patients over the phone. I work with, nursing home patients that are complex, psychiatric patients over the phone. And there's a line as to what's appropriate and what's not appropriate. Here's the problem. That line is different for every doctor. And you really can't draw the line because depending upon the doctor's experience, what they feel comfortable with, what their area of expertise are, what the problem is, it might be appropriate for people to work on kidney stones. I had people with 80, 90 kidney stones. Well, if this is their 91st, that's probably going to be appropriate. Somebody with blood in their urine, it might be their second one, that's probably not appropriate. And there's no book that you can write that down. And you just have to trust the people doing the work to solve the problem for you. Here, what I would encourage DMS to consider is, as their telehealth and telemedicine matures in Kentucky, to keep in mind that your primary care workforce has done very well the last couple of years with COVID as our example, as our working example, saying, even using a telephone, using some video, using some more sophisticated technologies, we've been able to help manage this for you. I don't know what the outcomes date is. We were trying to look at that earlier this year, but it's a little bit too close to it. But we feel like we're doing a pretty good job, and we would hope that you'll keep that venue open. There are just a lot of elderly people that want to use the phone, and that might take away some things, like if they have a dermatitis that we need to see, well, they may just have to come in. I understand that. Or maybe we can get their daughter to use the phone, and we could do a video chat. But a lot of our things are things that a lot of our problems are just spoken about. Mrs. Smith, I would like to do this with your blood pressure medicine. Can we talk about this? I'd like to do this and have you go check a lab work next week. Can we do this? And that telephone is invaluable. I would really hate to see that voice only, as I think it would really eliminate some of the at-risk populations that we're trying to engage. That's the way I would see it. And that would be my plea to them. And I think what you're seeing around the country, and that's what these articles are suggesting, that I think you're seeing these things to be beneficial. And I guess I would leave it at that, unless one of the MCOs has a different way to look at this, or would like to chime in, or Dr. Terry would like to chime in, or Lee, if you want to say something.
This is Angie with Medicaid.
Hey, Angie. Thank you.
Hi, are you saying what you're wanting to keep the phone part?
Yes, ma'am. I think what we want to try to tell you is that there's a place for the phone. I'll speak to primary care, but I think that I was trained, as people on this committee probably know, I mentioned it from time to time, I was trained by Toyota. In their engineering, when they look at their lean systems, again, you heard me allude to it earlier, they say, let the people doing the work solve the problem. If your primary care workforce, or if your specialty workforce says, listen, I can take care of this matter on the phone, I think we need to really trust that they can take care of it on the phone, because if they can't, they're going to say, you know what, we can't do this on the phone. We need more. We need a video. We can access that. We'll find a way to do it. We need you to come in. And I would encourage you to say, let's keep them engaged in whatever the technology is that supports the provider. If that's voice only, if it's video and voice, if it's some other more sophisticated, I would encourage DMS to say, yes, keep all of the above, because your workforce will add the amount of technology that's appropriate for the encounter. That's what we do in our office. And I think you'll get your delivery model will work better that way for you.
Well, I can tell you with the unwinding with the PHE that we're looking at everything that regarding telehealth, as well as what we have been utilizing for the past couple of years, are allowed based on getting a waiver from CMS to provide those things. Everything's being evaluated, and we appreciate your input on that aspect of things. I do have some data I can show you right now. I mean, it's not specific to
Well, I'd love it, Angie. If you have a couple of minutes, I'd love it if we can pull it up.
If Aaron will let me share, I will do that.
Hi, Angie. This is Donna. I just made you a co-host so that you can share.
Okay, thanks, Donna. Didn't realize that Aaron wasn't here. Okay, let me see what I can do here. So I'm hoping that you can see this. And this is 2019 through 2021. What you'll see here is telehealth utilization in 2019, pre-COVID. Then we have March 2020, when COVID started rearing its head and we were all in the process of closing down. And then you have April of 2020, and this, let me get this. Where you can see, but this is all through 2020 right here. And then you saw a spike in January of 2021 of use of telehealth. The light blue is the fee for service, the MCO is here. And that's when, you know, Delta started. And we had some challenges with that. And the start of vaccinations happened in this time period. And as you can see, there was a decrease in the use of telehealth during that time. Any questions on this screen?
None. Thank you, Angie.
Okay, and well, obviously I'm not doing a very good job on this. Here we go. With this data that the top utilizing providers for telehealth during this time was 5 out of the top 10 were related to behavioral health.
Well, I have an idea that's going to continue, maybe get worse. You know, I can tell you in our office, I can tell you from the Board of Medicine, wearing that hat, I mean, we're seeing more and more trouble. People, no offense, they just come in and they're just mean and they're mad. I mean, I've never seen anything like it, Angie. I've just never seen anything like it. I've seen people that I don't know what to say. I mean, I've just seen people act in ways that I never thought that they would act. It's been really difficult.
And this is just a graphic of the top provider types by count, and the community mental health centers utilized it primarily. Let's see. We did an access and availability study. We do this every year with our EQRO, and it's basically they do a secret shopper calling providers to see, you know, if they're available, can do routine visits or urgent visits. And looking at the data, when we did this was in December of 2020. We asked one of the questions was if they had telehealth, and if so, did they offer a telehealth visit? And also a question about whether or not they were asked about COVID symptoms or exposure. So like I said, this was during 2020, December 2020, and probably happened in, some calls were in January of 2021. But a telehealth visit was 18% of the calls, a telehealth visit was set, 81%, 82% was not. And then of those calls, 87% used telehealth, and 12%, 13% did not. And the majority of those calls, they were not asked about their COVID-19 symptoms or exposure.
Well, my thought on that just briefly would be that as time goes on, I think this likely improves. I think as physicians get more used to the technology, as the patients get more used to it, I think it'd be one of those things like that. I think will be one of those things that will disqualify a health professional. If they can't conduct this work, then they're not going to be at the market, and a family will, or a patient will just go somewhere else. This is going to become, I think this is going to become the standard of care, which is, well, you do some work like this, don't you? And if you don't, we say, well, why do you not do this? We are going to go somewhere else. But it's going to take a few years, but we always knew it would take a few years. It's moved a lot quicker than we thought.
Well, I think COVID made it increase exponentially. And I think, you know, it does show that it can be utilized.
Yes, ma'am.
And this is telehealth versus other encounters. And basically in April, of the encounters or in this claims that were submitted, 50% of them were telehealth claims, compared to around 25% of the submitted encounters. So basically, there were 50% of the encounters submitted were telehealth. If you're wondering, I did a presentation on this, so that's why I have this information.
I think you've shared this with us before, Angie, and it's very good data. And I'm glad you reminded us of this too. Thank you.
All right, so I've already shared this, so I will quit sharing.
Well, no, we've seen it before, but again, this is one of those things where you have to see it a couple, 3 times for it to make sense. And it'll mean more next year that we can take what we have and we can contrast that with, year after year. But I would thank you all for doing such a great job on that. Thank you, Angie.
Okay.
Anybody else want to chirp in on this one before we move on to our 5th agenda item? I don't want to press this too far, but I don't want to belabor this one if we've accomplished what we wanted to.
Real quick question for Angie. So this telehealth stuff I find really fascinating because I work with some folks from my master's program that run telehealth shops. And the one that maybe some folks have seen about is called Cerebral, and they're under investigation right now because they had a whole bunch of mostly APRN providers that were in other states but had various state licensure, and they were putting everybody on Adderall. And is there a way to support, for DMS to support folks that are, especially physicians who are doing telemedicine from the state of Kentucky? So they're located in Kentucky for Kentuckians, and to maybe not support as strongly outfits such as Cerebral. Does that make sense?
Well, are you talking about contracting with them?
I guess from a regulatory standpoint. So right now, I think one of the docs referenced, a telehealth doc in Wyoming who might have a Kentucky medical license. To me, just as a physician, and this is not as an MCO person, this is just, I'm a practicing doctor. And that's very different from being a Kentucky-based doctor at my office who chooses to see some of my patients remotely because it's better for them and maybe better for me. Does that make sense?
Looks like Jonathan's come on, so he can speak to that.
Well, I wanted to mention that House Bill 188 from this last session, and then we're also working under House Bill 140 from the previous session. Our hands are a little bit tied about how we bring in out-of-state providers and in-state providers. So we're working through that, but right now there are some limitations on how we could someone who is duly licensed, duly enrolled, duly credentialed, and providing telehealth services within their scope of practice, scope of licensure, and they're not limited by any professional criteria or anything like that. The state law is pretty clear. That's about as far as we can limit. And it appears that when legislation has been passed, that it is to open things up and to more fully force things to open up. So our ability to restrict is becoming more limited.
Tim, if I could take a swing at that pitch, I'd like to at least come behind Jonathan and tell you what you're looking at today is not the landscape that was there in 2006, 16, 17, and 18. And this really has to do with how things work through their way through the legislature. It was first brought up by Steve Riley in 16, 17. And with most initiatives in the Commonwealth, they take about 10 years to drive. This one went actually in 2 years, which was sort of miraculous. In 17, 18, Ralph Alvarado from the Senate put forward 112. But in order to get that through, again, you're looking through the lens of COVID and what this has done for us. we were one of the first in the country to really drive this, saying, well, can we take care of Kentucky practices because these people are paying taxes? They have to maintain these clinics, and we're seeing it the same way you see it today. But in order to drive the legislation through this, there was, as you're, I'm sure, intimately familiar, our insurance partners had a lot to say of this. And so this is what was the sausage that came out of the sausage maker. So I think a lot of us had hoped that we could try to keep the Kentucky physicians supported. And again, I think that as we work through these things, these mechanisms and these delivery models will be tailored over time. We just want to make certain that our Commonwealth physicians are supported. We see it the same way you do. I don't think, again, in the free market, I don't think that I want to try to exclude people that are honorably practicing, but it sounds to me like that you all have a kind of you found that 1 or 2% of people that are problematic, that are just doing Adderall online. And, I don't know about that. I'm probably best not comment on that type of practice. That's not what we're really working with in the majority, the great majority of the work we're trying to do. So in fairness to DMS and everyone else, this is just the way the legislation came through because it was the only way they could get it to pass. Great question.
This is Twin Tran. I like to opine regarding what Dr. Hutchins said and everyone regarding the telehealth. I completely agree with Dr. Thornberry in that telehealth should really be utilized as an additional tool in a physician's tool belt. There are times and situations where the patient may be served via face-to-face. And then, of course, for convenience, there are times when it's appropriate to manage the patient via telehealth. And then, of course, there are times where it's convenient for both parties to manage this via telehealth. But I think the clinician needs to make the determination as to when it's appropriate. And whether we use audio only or visual and audio or the combination of all, I think it depends on the situation. One of the comments and that I really want to follow up on is regarding something that Dr. Hutchins said. And we need to figure out, and I understand what Jonathan said, we do need to be very cautious though. If Dr. Thornberry is making a determination to see this patient via telehealth, the option for that patient to come see him in his office, should something not go well, is always there on the table. And this is just a spectrum of management. On the other hand, when you have people, corporations, venture capitalists from St. Elsewhere, New York, seeing patients in Kentucky, we are contributing to this problem of creating the void in Kentucky, because I doubt these physicians from St. Elsewhere are going to ever relocate to Kentucky to contribute to the building of Kentucky. Instead, they're taking our resources out of the state, and we are going to go back to the same question we asked: why would I, as a physician, want to stay here when I can go elsewhere? The other thing I want to point out is in the addiction space, one of the things that we are starting to see, and I voiced this concern to Dr. Alvarado, is a similar abuse that Dr. Hutchins mentioned earlier. We have physicians who are coming to our clinics because they want to leave the practice. People are doing 5-minute telehealth visits. I just can't imagine anyone managing anything, let alone a very complex situation like opioid addiction, in 5 minutes. And by the way, you don't do any of the other necessary things that are required to have good care: monitoring, psychotherapy, none of that. And so I question the validity of some of these practices from St. Elsewhere. I get it, seeing the patient face to face, and then for convenience sakes, because he's got COVID or his car broke down, you go ahead and conduct the telehealth just to get him by. But then the next visit, you're seeing him face to face. You're going back to the standard of care. That's one thing, but to allow a continuous spectrum of care delivered solely via telehealth from St. Elsewhere, I think is a very dangerous path. And I think again, I'm very biased because I live in Kentucky now and I care about Kentucky and its future. I think it's a very dangerous path to allow to begin.
Well, let me, thank you, Dr. Trent. Let me try to put a bow on this and say that it looks like today that we have really our MCO partners, we have your physician partners kind of trying to inform our DMS partners that there may be some issues with some of these out-of-state providers. And this is something that would have to be taken care of it from a regulatory point of view, and maybe in their work with the legislature and their work with the executive branch that they can communicate or echo some of these concerns and make something they may wish to investigate a little further. I also think that through GMLS, through KMA, through Lexington Medical Society, that there are ways from the business side of medicine to try to move forward in this direction. But I think if we're going to move forward, then we probably should all try to have a common vision. And it wouldn't be inappropriate at some point, again, if we ever do have some type of summit where we're talking together or some roundtable where we can get together and at least work toward the better care of Kentucky patients and how this might mean. And I would say, we probably close, Jonathan, you're a very senior person up there. I mean, I would leave it to you to decide what's the best way to do this. Again, we're not here to tell DMS how to do their work. We're just trying to inform you on the concerns we have. Would that be okay if we left it at that?
Well, I don't know that I'm a very senior person, but
you're always around when there's a big problem. So that's all that I know. I don't know what your title is. I don't know what you do, but I know you're just always around. So
me neither.
Lee, Angie, I would just say that that's a world that I don't frequent. I'd never put Dr. Terry on my line. I would never do that to my colleague. She'll figure out where she needs to be. So is that okay with you guys if we leave it there?
Sure. The more information we get, the better. And I did want to mention that this is something that we really intend to track and study and things like that. So the more information we get, the better on this, because this is definitely an area of interest for us, and addressing it is a big concern.
Well, I don't want to offend anybody, but I thank all of you all for being here. I really do. If it's okay, I'm going to move us on to respect your times. I feel like I'm between you all and lunch here, and it's a bad place to be. I have item 5. This is an update from DMS on our contact lens coverage. If somebody could chime in on that, and then Ashima, could you lead us on our behalf after they finish, please?
Yes.
Does anybody from DMS have anything for us on an update?
Is this update on the contact? I thought that is this the contact lens for under 21 or over 21?
It's for over 21 to continue the coverage for contact lens.
Okay.
We had made that recommendation in late 21, and I don't remember ever getting a response from DMS about that.
You made the recommendation to the MAC.
Yes.
Likely our response to the MAC was that we would be happy to review it. I'm unfortunately not aware of what the response is on that. I know that we have to do a fiscal impact, and I believe that from the fee-for-service side of things, we're still, I want to say this, and I know it's frustrating to you all, it's in line. It's on the table. You have, you made the recommendation to the MAC. We track those things. So we are working on it, but unfortunately, it hasn't risen to the place of completion just yet. So we will, you can leave it on the agenda. You can make another recommendation to the MAC, whatever that you feel like doing on that.
Well, thank you very much. I think, Ashima, would you feel okay if the reason we didn't speak to it before is because we did not have the last meeting being in session. We want to really have a more productive meeting, which is, I thought we had a nice meeting today. Would you feel comfortable, Ashima, maybe making an inquiry from the MAC point of view we can always bring it back on our agenda if that will help you.
Are you suggesting just at the next MAC meeting bringing it up, or?
Yeah, I would see if, I don't know who chairs the MAC, but maybe we could make an inquiry from that side and keep this open on our side too, to
Okay, I
help
can do
you.
that. I
Yeah,
can actually suggest that to Beth.
great. And like I said, we'll keep this open from our end if we need to. Is that okay with
Yeah,
everybody?
that's fine. I just want to
Oh.
make sure it has not been forgotten.
It's not been forgotten. We've not forgotten it, but we certainly made our recommendation. We'll keep that open. The last item is we wanted to chime in about the possibility of trying to get together in person. That might be in July. Does anybody from the MCO or DMS have any concerns about not wanting to meet in person? Would that make them uncomfortable?
I actually will be in New York that week, so I could meet virtually, but not in person.
It's a tough life, but we're glad you can travel. Well, Dr. Tran has brought this up before, and at least a few times a year. I know that we've kind of, a lot of our meetings have moved virtually, and it really makes our schedule a lot easier and more productive. But it may not be a bad thing once, maybe twice a year, to get together to see the players, so that I just find that in these very senior level meetings, it really helps a lot if you can, I think, see the people, talk to them, have sidebar conversations. I just think there's a lot that can be accomplished. And I would encourage our MCL partners to have their directors there. I'd encourage DMS to have their leadership there if they feel comfortable with that. But from our point of view, from the physician point of view, is there any objection to meeting in person in July? Ashima notwithstanding.
This is Dr. McIntyre.
Yes, sir.
I'd make the suggestion that we do it in September, because July meetings tend to end up being canceled.
a wise gentleman, and there's good reasons sometimes. How about we look at September? Would that be okay? What a wise thing to do. Would that be a motion, Dr. McIntyre?
Yes.
So notwithstanding some type of change in COVID or some other problem, we could look at September, and as we move closer, it'll become a little clearer. Would that be okay? Is everyone in favor of that?
Yes, that's fine.
All right.
Yeah.
Well, thank you. We'll consider that without objection. That'll put
I'd
us
like
to,
to,
ma'am?
Dr. Thornberry, just real quickly let you know that Medicaid does have telehealth equipment installed, so at our conference room, so that there can be a partially hybrid meeting if you'd like.
Well, we would always welcome that. I think we're, as a society, I think we're trying to figure this out where it's obviously gone, the pendulum has gone one way. How much will it come back? I think it'd be very wise for us to consider that if we have that opportunity, and we can see how that works and if it works well for us or doesn't. Again, I think for those people that can come, I think there's a lot of wisdom to it, but I would leave it to you all. You all are in very senior positions, and you know what's best for you and your effort. But I would plan on, yes, Dr. Terrio. Yes, ma'am.
I would just say the room with the hybrid equipment, the commissioner's conference room may not fit 25 people. And I'm just noticing that's about how many people were here. And so if you do a hybrid, that might be better, because I don't think 25 people can fit in there. It would be tight.
I can honestly say I don't think I've ever been to a meeting where there were 25 of us all together at once. I don't think so, but I'd love to see that. Will, how about if we work toward that direction in September, and as we get closer, since our DMS people generally help us with that, maybe you could kind of give us some coaching on what you think might be the best facility for us, and we can put out a feeler on how many people would like to meet in person. I certainly will be there if we meet in person. I would like to do that if we can. Okay, so can we leave it at that then? If not, if there's nothing else on anybody else have anything new or on the agenda we need to speak with, I have us at 10:30. There being none, we'll call this meeting adjourned. Again, we may have a July meeting. I kind of doubt that. It's generally customary that we don't. And I'd like to thank Dr. McIntyre for reminding me of that. Have a nice weekend, everybody, okay? And enjoy your summer.
We'll see you. Bye-bye.
Okay. Thank you again for
you.
coming.
Bye-bye.
Sure.